This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. Welcome to episode 112 of the Psychcast by MD Edge. In this episode, Dr. Mary Moller joins Dr. Lorenzo Norris to discuss Polyvagal Theory. And later, Dr. Renee Kohanski is here to give us her thoughts on precious relationships. Remember, the Dr. RK segment is available following the interview portion of our show. This episode comes with robust show notes authored by Dr. Jacqueline Posada. Of course, the notes include biographical information for each guest, as well as an outline of topics covered in the conversation. We have some exciting news for the Psychcast. After dozens and dozens of episode show notes authored by Dr. Posada, she will be stepping in front of the mic and hosting a special conversation related to the mental health implications of COVID-19 on patients, the general public, and of course on healthcare providers and workers. We love working with Dr. Posada, and we can't wait for all of you to finally hear her voice. Remember, if you have thoughts on how COVID has impacted you, your patients, or your colleagues, please email us at podcast@mdh.com. We would love to hear from you and to hear some of your feedback. Okay, without any further delay, please welcome the host of the Psychcast and the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris.
Hello, everyone. This is Dr. Mary Moller, and I'm Associate Professor of Nursing at Pacific Lutheran University in Tacoma, Washington, where I serve as the coordinator of the Psychiatric Mental Health Nurse Practitioner Doctorate of Nursing Practice Program. And I'm also in practice at Northwest Integrated Health, which is a integrated substance abuse, primary care, and psychiatric outpatient center.
Hello. This is Dr. Lorenzo Norris, editor-in-chief of MD Edge Psychiatry. We are pleased to have with us today Dr. Mary Moller on today's Psychcast. Dr. Moller is going to talk to us today about polyvagal theory of anxiety as well as social engagement. I can't think of a better time really to really talk about this theory in regards to what we are facing right now with the COVID-19 pandemic. So, Dr. Moller, please welcome to the Psychcast.
Thank you so much. I look forward to our conversation.
All right, very good. So, Dr. Moller, let's kind of really start maybe just from the ground up, so to speak, because many of our listeners may or may not be familiar with polyvagal theory. And can you just maybe give us a bit of a brief overview or a guide through really what polyvagal theory is and how it relates to anxiety and social engagement?
Thank you. I would really enjoy doing that and look forward to this. So Dr. Stephen Porges is a physiologist who published his theory of polyvagal in 1996. He's a researcher at University of Illinois in Chicago. And he actually was studying newborns in a NICU and was curious that some of these newborns were always bradying down with low heart rates, and some had really high heart rates. And, of course, we know the role of the vagus nerve in cardiac stability. So he just was curious, and he started studying the vagus. Excuse me. He started studying the vagus nerve in relationship to cardiac function, and he started with looking at reptiles, and discovered that reptiles only have an unmyelinated dorsal vagal. And in studying then mammals, realized that we developed a myelinated ventral vagal. And the difference between the two basically is we know the vagus branches, and the dorsal vagal, and I help my students remember it by thinking of DV. And in my world, I think of domestic violence. So when that dorsal vagus nerve is activated, you get that hit in your stomach and something is really wrong and you don't know what it is exactly. And what it will do then is it shuts down basically from the diaphragm down. Excuse me. Whereas the ventral vagal innervates from the diaphragm up. So understanding the role of those, which we can get into in a little bit, helps us understand our own physiology of fear. And then, of course, we've got the autonomic. Excuse me, I've got to clear my throat. I don't know what that is, but
take your time.
Let me drink some tea here. So we'll just start that whole section over.
Sure.
I took my zinc. See, now, do you know, I read something that COVID can't live in the presence of zinc. So I've been doing my Zicam nasal spray, and I shouldn't have done it right before this podcast. So, all right, I hope that that's cleared out. I ate my oranges, so okay.
Okay.
Well, we'll just start that over again.
Sure.
Okay, so basically, the polyvagal theory was developed, articulated, and published by Dr. Stephen Porges in 1996. He's a researcher, physiologist at University of Illinois, Chicago. And he was studying heart rate variability in newborns in a NICU, and was just really puzzled by how some of these newborns were trying to brady on down all the time with heart rates, 50 or less, and others were super tachycardic. And recognizing, of course, that heart rate is regulated by the vagus nerve, he started studying the vagus nerve. And he started by looking at the vagus nerves in reptiles, which is a fairly simple unmyelinated dorsal vagal that basically innervates from the diaphragm down, which the function of that will allow a reptile to play dead and, save their life. And mammals also have a dorsal vagal. And you can see a rabbit can play dead so that an owl flying over would think they were dead and not want to eat them. So we know also that humans in the function of dissociation also can shut down, but it's not a play dead, so to speak, as you see in lower mammals or reptiles, but the function is there. Well, he also discovered that in mammals and humans, we developed evolutionary a myelinated ventral vagal, which controls from the diaphragm up. And ventral vagal is what allows us to be socially engaged with others, to be fully interactive in our environment, to read one another, to understand the subtleties of the tone of voice, for example. So when he published this, it made its way, interestingly enough, into the psychotherapy world. And I don't know exactly if they really looked at this as understanding some of the science behind what we would typically think of as fluffy kinds of psychiatric interventions, deep breathing, mindfulness, energy regulation, etc. But what we now know is by purposefully helping patients understand this vagus nerve and then how it interacts with the entire autonomic system, helps us use some of these interventions, such as mindfulness, in a very purposeful way that helps the patient focus on keeping their ventral vagal the dominant feature in their nervous system as opposed to this dorsal vagal. So a good way to think of the differences that I teach my students and my patients is if you think of the initials DV for dorsal vagal, makes you think of domestic violence. So when people are afraid, when your body senses danger, you get that pit in your stomach, and something's wrong, you don't know what it is. And Porges coined a word for that called neuroception, spelled Neuroception. And neuroception logs in long before perception. So neuroception is basically our unconscious threat detector. And that's what signals this entire process to happen. within our bodies. So it behooves us to really understand this so then we can operationalize it for ourselves as well as for our patients.
Dr. Moller, you definitely have given us an absolute overview of the vagus nerve as well as a number of things to think about in terms of polyvagal theory. What I took from it is this, and help me out to make sure I got it. I think about the sympathetic nervous system, which most people are familiar with in terms of fight or flight. When I think about polyvagal theory, I think about two other main things, the freeze and the social engagement. Ventral vagal, social engagement, freeze, dorsal vagal. Is that accurate?
Yes. Yes.
Okay. All right. So I think another thing in regards to this is that it certainly adds a lot in regards to these how our bodies work and prepare us. And I do appreciate the fact that we have this, in terms of polyvagal theory, this other system that is designed, if you will, for social engagement. Now, one of the things in regards to polyvagal theory is that it can explain a lot of things that we may or may not, or give us different perspectives on, if you will, different phenomena as it relates to adaptation to stress or things of that nature. I was wondering if you could tell us a little bit, one of the things I was curious about is what polyvagal theory informs us about dissociation.
Okay. I like to use the analogy of an upside-down stoplight. So instead of red at the top, we've got red at the bottom and green at the top. So we want to be in a state of green. We like to go, right? Social engagement is you and I interacting, but the interesting part, I'm going to segue just a second, while we're into this social distancing with the COVID-19 restrictions, we're not able to fully socially engage even as a society, and I know we can come back to that. But when you think about social engagement, I think we're going to think about it very differently after we don't have to socially distance anymore. We need each other to interact. We need to see, feel, smell, be in the presence of each other. So social engagement is listening to the subtleties of the tone of voice, watching eye contact, watching proximity, watching how people can be open and have not distance from people, but have what we call proximity that's not invasive. So social engagement is recognizing that, if you know me and I know you, you can tell if my voice changes or if I, quote unquote, don't sound like myself, right? That's social engagement. And that's being able to, hold somebody's hand and comfort them and feel their pulse and connect. It's all about what we call attunement. That's one of the words that we use therapeutically. I need to attune with you, and we need to attune with one another. So that's the green light, and that's going to be at the top of our stoplight. When we get this sense of neuroception, something is right, there's a fear mechanism that kicks in. And we've got our wonderful, wonderful amygdala, okay? This is the central nucleus of the amygdala that notices that. So that information gets processed quickly, and it's the periaqueductal gray area in that tegmental portion of the midbrain that goes into operation. And it kicks in through the descending autonomic tracts. It gets projected to the nucleus raphe magnus. It gets, goes through the descending autonomic tract and hits the pyramidal tract. And we either get as descent, right, which is fight. So we go into the yellow light now in our stoplight metaphor. So we're in the fight mode, okay? Or, this is too big for me to fight. So if you are in a domestic violence situation or you're a child who's being repeatedly abused, the child can learn fighting doesn't work. I have to flee. Well, maybe in a domestic violence situation, the victim partner can run out, but oftentimes individuals are trapped and they can't run. They can't flee anymore. So what happens when that occurs, it goes from the yellow light to the red light. And the red light then becomes the beginning of the freeze mechanism. So when you start shutting down, we've all been with patients and we watch them shut down when we're talking with them about, their life experiences, and they're very painful. And when we see them, because we're socially engaged and we're attuned with our patients or with one another, a good friend, whomever, it doesn't make any difference, and you watch that shutdown start to happen, the eyes glaze over, and we watch that entire affect flatten down. The eyes glaze over. The voice changes. The body starts tightening in, and they may start, their hands may have been open and out, and now they're clasped around themselves. And that's that shutdown. So the only way to stop the shutdown is to get connected with that patient. And the biggest connection is through voice and touch. Obviously a safe voice and safe touch. So we want to get that red light back to the yellow.
Okay. All right. Thank you for the stoplight, if you will, imagery. Now, I'm thinking about this. So let's say we're a clinician, all right, and we're working with a patient, or let's say we're working with a patient, and we actually see, if you will, them entering in, or they are in, for lack of a better word, a freeze or dissociated dorsal vagal red light place.
Yeah.
All right. Now, okay, so we're there as a clinician, and let's assume that our clinicians are in a positive parasympathetic ventral vagal social engagement area.
Yeah.
All right, we're there. What would polyvagal suggest in terms of, as you already mentioned, touch as well as voice? What would polyvagal theory suggest as a way for the clinician to help that patient in terms of the voice get out of the freeze state and back into a social engagement space, which would be the dorsal vagal or ventral vagal system?
Right. So the way I, again, help my students, so if we think of DV, dorsal vagal, as domestic violence, I think of ventral vagal as VV, as very vagus. So Vegas. It's very active, and it's interactive, and there's stimulation, and there's music, and there's people, right? So we want to get into this VV, this ventral vagal state,
right? And
it relies on a connection between the face and the heart. So the heart is above the diaphragm. So one of the first things that we need to do with the patient is say, you know what? I can tell that this is really, really stressful and scary. I just want to take your pulse. And you grab that patient's wrist and you take their pulse. And you know, are they tachycardic or are they bradycardic? And we'll say, oh my goodness, your heart is going 120 beats. We've got to get your heart slowed down. I need you to look at me. And you just soften your voice, not quietly. You may need to quiet it down. But when I mean soften, it's, stop the agenda that we were at in this discussion. I don't care where you're at in the psych intake. It doesn't make any difference. Right now, this patient is activated. And so you soften that, and you go, you know what? We're not going to talk about what we were just talking about. I'm going to ask you to focus with me. I'm going to breathe with you. We've got to get your diaphragm lowered, because what will happen is you see the patient, their shoulders are tense, they may even have fists, their face is flat, their voice has gone to monotone, and they're in their dorsal vagal. So by connecting, it's called attunement. We get with this patient and say, okay, I'm going to breathe with you. Listen to my voice. Look at me if you can. If not, just close your eyes. And I will literally take them through deep breathing. And we'll do 3 sets of deep breathing. And how I do it is I'll say, okay, I'm going to take my hand. We're going to hang on to you. I'm not going to let you go. I want you to feel my presence. I'm safe. And we're going to breathe. So breathe in really deep, push out your belly. We need to get air at the bottom of your lungs. And I ask you to envision the bottom of their lungs, because all they've been doing is hyperventilating, right? So breathe in, and then I count to 10. I said we're going to hold it to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We're going to blow it out. And then when you think you've got all your air out, squeeze out more air. And initially when they do that, it's very superficial, right? And say, okay, great, we're going to do it again. And then we do it again. That is a 45-second to a 60-second intervention, and you have connected with that patient. You've got to get the diaphragm expanded and shut down, literally shut down, push down, put the pressure on that dorsal vagal. And then the patient will go, oh, okay. And invariably, I'll hear a little prosody back in their voice. And I'll say, okay, so let's just sit here, and I'll take their pulse. Generally, it's come down 10 or 15, maybe 20 beats. And I'll say, you know what? You can do this anytime, anywhere. And it was really funny. About a month ago, I had a patient that had just a terrible assault, and she'd been kidnapped, and it was awful. And as she was telling me about it, I watched her. She was starting to go into dorsal vagal response, and I said, okay, when I talk about this, then I took her pulse, and she had the terrorized look in her face. She'd gone, flat in her face, and her heart rate was, I think it was about 118. And anyway, got her breathing, and she goes, oh. So when I saw her a couple of weeks later, she said, I just have to tell you, I was able to deep breathe myself to sleep last night.
Wow.
And I said, that's not a pill. You don't need a pill for that. This is about you recognizing your body. So I do a little brief teaching about what breathing that diaphragm does. I said, it's like a reset button. It's going to reset your nervous system, and you're going to be able to stay present. Because what happens is in dissociation, as we know, they just go away, right? They go away. And I want you to stay present. So that's a kind of a brief version. But you've got to get the heart and the face connected. That's the linchpin to social engagement.
Got it. I think that, one, thank you for giving us that example. As I was going through it, I was trying to imagine it myself, and I think one of the key components of it is the use of, I would almost say, taking the pulse or a physical exam, but you're using it in such a way that is so therapeutic, and you are, one, you're letting the patient know what's going on, and you're absolutely, I won't say external pacemaker or what have you, but that connection. But yeah, you are, and that's what when I think about the connection that you're establishing with the patient, and it's a very important one, I'll almost say, because their breath after a point, as well as heart rate, is mimicking yours or getting it to a slower pace. And what I would say compared to, because I've seen some of my colleagues who are very gifted, in regards to working patients through mindfulness or deep breathing exercises and seeing it and having the patient take their pulse. But that's very different than you taking the pulse and you actually verifying with the patient and yourself where that heart rate is. And it's all the difference in the world. And I go back, I heard what you said about that body and heart and face connection. And what it makes me think about, when I was training, I had a clinician, an attending, and I blank on his name, but we were working with a patient who was having an extremely strong response to, if you will, a cancer diagnosis in terms of anxiety and things of that nature. And he went to the patient, and the patient was trembling. The first thing he did, it's very similar to what you said, Dr. Moller, and I don't think he was practicing Polyvagal Theory. He put his hand on the patient and just stayed there on the patient's hand, and did not. And the patient just started to calm down. And the clinician and the patient looked at us, and he said, "You young clinicians do not understand the value of touch." And when you were talking about this, it also made me think about how we train our current physicians, because I'm going to go back to what you said in terms of domestic violence. What type of difference would it make if our clinicians, all clinicians, really started to, which they should, if you turn your physical exam, your use of the stethoscope, and you really are aware of where your patient is at, and as you're taking that vital sign, you say, hold it, wait a minute. You're in a different place. Before I give you a pressor or what have you, or this or the other, let's just actually use this touch so I can actually monitor and work with you in a therapeutic way. All right, as opposed to just before, obviously context depends before we go to a medication. But again, what I thought of in terms of, because I always think about what are some of the differences compared to just you working with a patient in terms of a mindful breathing or something of that nature. It is the touch and the engagement of yourself and that if you will, that heart and face connection. So I really like how you explained that. Now, with that being said, Dr. Moller, I want to actually go back because you gave us a beautiful example. How in goodness' name do we practice that in the context of telehealth, in social distancing, and I mean, I personally do not have telekinesis or anything of that nature, so I cannot reach and touch a patient even if I wanted to. What would you say? How is polyvagal theory, one, can it be modified for telehealth? And also, what does polyvagal teach us in regards to what patients in society are likely feeling in regards to this social distancing?
Well, that's a can of worms that we're in total uncharted waters, right? Mm-hmm. So this past week I did 18 hours of face-to-face online sessions, and as I said, our patients in our clinic have all had a polysubstance problem, mm-hmm. And all of them have very severe PTSD. And then, of course, we've got our underlying bipolar, and right now, bipolar is blooming because mm-hmm. daylight. So this week it was watching the schizoaffective patients, activating, and our folks with bipolar, and then, of course, our PTSD patients. Everybody's activated, and they don't understand, as we don't. None of us. We've never had to do this before.
No.
And so how our clinic is working the clinic is staying open, and the front office staff are there primarily. And the patients are taken to a room, our normal room, and the computer is set up for telehealth, and they're in there alone now. And they're looking at me on my computer screen. And we see each other, but you don't get direct eye contact when you're on telehealth unless you have a really super sophisticated system. Mm-hmm. For me, with my laptop, if I want my patients to see my eyes, I have to stare at that little white light of the camera, which means mm-hmm. when I take my eyes off of watching them, but I do that periodically so they can see my eyes. And then I have to turn my eyes back from the camera light to the screen, and I can't take their pulses, I can't touch them. So at this point, what we're doing is recognizing that and saying, okay, this is temporary, but what can we learn from this? And you can see how important it is to stay engaged with someone. And for myself, I'm living alone now, so it's really odd. Mm-hmm. My husband died last year, and so this is really a time for me, like, oh my goodness, I've never been sheltered at home alone. So mm-hmm. I don't have anybody to engage with. So families have a really beautiful opportunity to take this and say, okay, we really have to be mindful of how we're interacting. But for our patients, I think all we can do right now is acknowledge that, you're feeling probably some extra anxiety. I do have my patients take their pulse because mm-hmm. I taught them all how to do that. Tell me what your pulse is doing. If it's certain high, we're going to breathe together. So we still do our breathing together, but they're not attuning with me because I can't physically touch them. And, for me, I'm a nurse. We have a license to touch. Mm-hmm. And physicians, have a license to touch. And what better way than to say, I'm going to take your pulse. This is not an invasive, process to take someone's pulse, but it allows us to touch. That's all you need. It's just those two fingers on that radial artery, and you have connected. And so when I'll do that with the patient, I'll say, okay, take your pulse. I'm going to watch you. And that's the closest that we can get.
Okay.
Not very many of my patients are living alone. Most of them are somewhere, or they're a group home. But I have a couple that are homeless, but they're together. So I'm more worried about my patients that are alone than ones that have someone with them. But I'm using this as an opportunity to say, okay, look at the importance of being with someone, even if you're 6 feet apart, okay? You're in each other's proximity. So that's the best that I've been able to come up with in this temporary new world that we're in.
Okay. Dr. Moller, and thank you so very much for sharing with us your experience in regards to working with patients at a distance. Here's a question, and I'm going to ask a few questions because I'm very curious because also the example you brought up. One, are your patients, for lack of a better word, do you ever use imagery? Are they able to maybe construct an image of when you and they have been working together, and even though it's not touch, if they can maybe go back a bit and go back to what it was and still simulate, maybe if they can't get 100% of the response, they can get maybe 50 to 60% of the response?
Yeah, I'll say, remember when we first did this? Remember when I first taught you about your pulse and how to breathe? I said, we can breathe together now. So that, recollection, imagery is an interesting concept. I have been a little reluctant to have people bring up imagery. I'll ask them to bring up maybe an event that felt good. And so I'll try to use like the events that I have shared with a patient when I'll say, okay, let's just get connected here together. The first time, right, when we're first engaging in polyvagal, and we teach them about polyvagal, and I teach them the initials and that kind of thing. And then we can draw on that. So the more shared experiences that we can draw on with our patients, the better. But, if you're in initial intake, you don't have any experience other than that moment in time. So I'll ask people to tell me, what was a really happy time for you as a kid? And then, ask them to go to that. So I try to give direction with the image so that they'll bring up a specific, like, a video recall, of a birthday party or something or whatever, as opposed to just think of, a happy place. I try to give them a little more direction with that. And maybe that's because I've worked with so many folks with, really serious psychosis that I try to make it really concrete. Okay.
And on that note, in terms of giving them some direction, again, I can imagine you just kind of staring into that white light and really trying to put all of your energy through the screen. But and that's that is tough. Particularly, I'm curious if folks or people from a different generation that use FaceTime or things of that nature would have a different experience with screens than I am 46 years old, so I don't. I said this recently in another sidecast. I am not used to FaceTime. I don't routinely do it, but I think their experience with it is a bit different than folks of a different generation. But that's something separate. But what I am curious about is you talked about not only, if you will, touch, but you talked about voice. Do you find that, because if we can't use the touch, we change our voice, and we could go, voice and language, that in and of itself, we could have a whole sidecast on that. But do you find that you do anything different with your voice in telehealth that you would do in person? That might be kind of difficult to, summarize because this gets into the art, but I'm just curious, is there anything that you do?
It's really interesting that you bring that up because I was finding myself intuitively making my voice more melodic, not just, sitting at the computer screen and entering their data and doing kind of a, an in-office, which can be a little bit, it can get routine, right?
Right.
So I'm finding myself, it was not conscious at all, but, you're working on your voice. And again, that took a different level of energy because I didn't have the patient's energy to bounce off of. Because, you know, when you're interacting with somebody face to face, you read their vibes, right? Their energy. We can feel that. And we can intuitively, when you're in someone's presence, change your voice.
Yes.
Soften your posture, sit back, etc. But when I'm on a screen and it's two-dimensional, and depending upon the room setup, they may be a little bit further away. So I found myself saying, please bring your chair closer to the screen. I want to be able to, look at your big blue eyes, that kind of thing. But I found myself being more melodic, and I thought, okay, that's an energy drain as well. Same thing with the graduate students that were on their cameras. And they found themselves saying, this is so much more tiring. So,
yes.
Yeah.
It is, and just listening to you made me think about some things. As I always say frequently, the best conversations that we have for the listeners are usually the ones that they never hear before we get on air. But Dr. Moller, I'm going to bring up something that you said because I think it's very important.
Okay.
You talked about, I'm having a hard time getting in rhythm because you're not going from room to room to room to room. And I found it very interesting that you said your voice is naturally becoming melodic. It's developing rhythm. It's developing movement because it naturally has to, because we cannot do it we can't do it collaboratively as we normally would with our patients. So right. Your voice is naturally adapting. My guess would be, this is just me, whatever, hypothesizing. Your voice, you were talking about that rhythm. Just listen to you. I feel like you're developing that rhythm in and of itself. And what I think about is great musicians or singers or folks of that nature. I imagine them, if they're speaking at a recording studio or something of that nature, how do they convey that sense of calm or emotion or energy with nobody there? And that's why I think it's very hard at times to record when you don't have the energy of other people with you. But when I hear you saying that, and I think about what our clinicians can take away from it, how can you naturally use your own cadence and tone to develop a rhythm or a sense of purpose in regards to what you do? And then when you get really good at that, you can convey that across, if you will, a computer screen or a phone. I think about the person who comes to mind. I think about the first time I heard Adele. I was like, as well as many others, like, whoa. Yeah. It didn't matter whether she was in the room or not. I felt her energy. Yeah. But that takes an incredible amount of patience, time, and skill, as well as effort to do it. But when you were speaking, that's what I thought of. Please go ahead, Dr. Moller.
Well, that's a really interesting thought. And what it made me think of was, okay, so you've got somebody in a recording studio. That is a 100% by choice, expected, scripted, planned for time. And you need that quiet time. You need to mobilize all of your own wherewithal to accomplish a task.
Yes.
None of what we're doing now is by choice. And, we all crave that silent time. And I'll say, oh, boy, I'm so glad I get to have this weekend all to myself with nobody to disturb me. That's choice. Mm-hmm. We have lost choice. And so how do we put choice and into establishing a new temporary normal?
Right.
How do we get a routine? How do we get we are creatures. We're mammals. We need routine. We work on rhythms. We work on rhythms based on sunlight, moonlight, high pressure, low pressure. And we know how we feel in these various situations. So now we have no choice. So what I'm finding myself as I retrospectively think about this over this past 2 weeks is, all right, I could no longer do all my students in one day because I only have one computer screen. So now I have to double my time and have one student do all her patients on one day and another one on another. So, okay, now, which is great, I'm giving more one-to-one supervision, but they're going to be graduating in 2 months as psychiatric nurse practitioners. So this is the rotation in which they're more independent, and I start them off and then I check them at the end, right? So now I'm physically present. Well, I'm remotely present because my name is showing up on that computer screen. So now they've got me in the room the whole time, which we haven't had to do that this year. So that's different for the patients. And one of my patients with ADHD yesterday said, she said, I've got these 3 screens I have to look at because both students are attending the sessions, right?
Right.
And me. And I said, I hadn't thought about that. She goes, it's really distracting. And I thought, okay, now I have to figure a workaround out for that. But I couldn't do that one on the spot, you know. But that's something that I hadn't thought about. And how about patients that have paranoia? If they're going to see you on the screen and you've got a graduate student with you or you have a trainee with you, and they're going to see 2 or 3 people on the screen staring at them. I mean, we haven't had to figure this out.
Okay.
We're trying to figure out, like I said, a rhythm, and so I'm figuring one out that's working. But it's new.
We are truly in unprecedented times, and that idea, figuring out a rhythm that works. How can we use polyvagal theory, whether in person as well as over, if you will, in telehealth settings, is very, very important. Now, with that idea of, I just want to touch on something, just make sure that we do, and I'm going to go someplace with it.
Okay.
We've talked about polyvagal theory in person as well as via telehealth. You've given us a lot of information in terms of, DV, domestic violence, VV, very vagus or whatnot, and fight or flight is sympathetic. All right. Now, help us understand a bit, because I think we need to, before we move on, is this principle, and you've mentioned it before, I want to say, of co-regulation.
Yeah.
Can you help us understand co-regulation and what that means in polyvagal theory and how it's going to maybe apply to that telesetting as well as in-person setting?
Right. So co-regulation is how we regulate ourselves in our environment.
Okay.
And when you've got an environment that's negative and frightening, either neglectful or abusive or both, the individual is left isolated.
Yes.
How many times have we heard people say, I'm so lonely, even though there are people in the house? It's because there's no co-regulation going on. People are not attuning to one another, or it's abusive or neglectful. So if we don't co-regulate, we don't survive and thrive. When we look at children that have failure to thrive, for whatever reason, they're not co-regulating with their mother. The attachment mechanisms are off for whatever reason. We don't know the reason, but they're not attaching. So if you think about co-regulation within the concept of attachment theory, I think it can help understand that. So when we think about those principles of attachment, we have proximity. You have that eye gaze. You have touch. You have lots of interaction with your face. I think of something that Bessel van der Kolk said 25 years ago when I went to one of his trainings, that he said the single most intervention to promote healthy brain development in a newborn is the presence of kind eyes. Kind eyes. And we watch our patients. You see them on an inpatient unit. They're darting back and forth. They're looking at, now the mean nurse is here, or the mean doctor is here, or the mean therapist is here. And it's all about the eyes. Sorry about that. So it's about the eyes. So co-regulation is basically, I think, a sort of a newer way to frame attachment.
Okay. We know, Dr. Moller, you've definitely given us a lot to think about in terms of polyvagal theory. And again, as I think about it, it's just, I think about that it's a very powerful and interesting way to really think about mind-body interaction and interplay and how they work harmoniously with each other, as well as you, the therapist, being a part of that. One of the things that I would say is you gave us such a description and you shared so much with us. I think going back to co-regulation and even in regards to environment and things of that nature, what are maybe some unintended benefits of telehealth and how it relates to polyvagal theory? Well, one, we kind of go back reverse. It's the eyes. We may be on a computer screen, but if we can convey those kind eyes and things of that nature, I think that can be very powerful in terms of helping our patients modulate and get into that very vagus or ventral vagal state. The other thing that I was thinking about, it was so powerful when we talked about our environment. Something really interesting has happened. Something's really interesting happened, and I bet people who've been on conferences or, if you will, whatever administrative conferences, they probably notice the same thing. Everyone's doing the conferences. A lot of people are doing it from their house. And you know what I'm getting now? I'm getting a peek into your house. I'm seeing aspects of you. I'm seeing aspects of your life. So one of the things in therapy, whereas before they usually come to our setting or our office, we're actually being imported into wherever their environment is. So it's going to be odd. It's going to be different. But they've never had that experience before. So even though we're losing something, we may be, if we're creative enough, we may be gaining something added in that, whoa, wait a minute. Now this environment, particularly if it was neutral, now can become a place of calming because I'm associating it with this person that I am working with and connected with being there. And then the other thing that I was going to say in terms of what I thought about in terms of that rhythm in regards to the tone of your voice, particularly if we're not able to manually work with the patient in a very visceral way to establish the rhythm through heart rate and breathing in person with the use of touch. When I think about that rhythm, I think that we connect to each other by all the ways that you mentioned, but we also connect through stories. We also connect, as you said, through shared experiences. We also connect through, and again, I kind of think about it in terms of music, and what I think about is the ability to recognize, contain, or transform pain, yours or someone else's. So all of those stories that we have, that we personally have right now, whether it is of loss, whether it is of tragedy, whether it is of we have not been able to attend graduations, of take your pick, they are there. Our true strength and connection is being able to take our stories, our own personal stories, transform them into our own kind of rhythm in terms of how we interact, and then people will feel that shared energy of connection that we are all experiencing, an unprecedented thing that nobody has. And hopefully through that, once you get that, it doesn't matter whether you're 6 feet away or 100 feet because we are all in the shared same experience. Not easy to do, but it is certainly, if you will, there and applicable. And then the other thing that I would say, I agree with you, it is so hard where we are at right now. But I would modify it just maybe slightly, what you said in regards to choice. I would argue that we are robbed of liberty. In other words, options. I would argue that we are robbed of liberty. Choice, I would argue, is the choice between the options we have. We may have very few options, liberty, but we still always have the ability to choose, and part of that choice is how we share our stories and connect with each other. So, Dr. Moller, I want to thank you for appearing on the Psychcast today, and I want to give you the last words.
Oh, thank you so much. I really like what you were just saying about liberty. And where my brain went when you said that was I flew back into what we've been learning and reading about the 1917 Spanish flu. Well, there certainly wasn't an internet. There wasn't telephones. There was telegraphs, right?
Yeah.
But people didn't have near the opportunity to connect. So if we're only connecting in 2 dimensions, how do we make that work? And like you said, I get to see some of my patients' dogs or their cats or that kind of thing, if they're talking to us from home. And I think that we need to make a point of telling the clinicians, you know what? You need to look at that camera and tell the patient, you know what? I'm going to be looking so you can see my eyes, and I want you in a minute here to look at the camera so I can see your eyes. And even though we can't do that at the same time, and see the screen, we're at least knowing that we're seeing each other. And I wanted to also leave folks with a thought about this neuroception, this sense of doom, this sense of danger. this unconscious threat detector because it precedes perception.
Mm-hmm.
So what we need to realize to help people if they've got that, something is wrong, how we use our senses, okay? So it's voice and it's touch, which we have voice, okay? And we can see each other. And how we listen is becoming more acute. So we're using auditory. And then how we speak is our vocalizations, right? So we want to watch the expressions on our face, the tones in our voices, allow your eyes to be seen with the patient, and acknowledge it. Not acknowledging it is not a helpful way to deal with this. We have to say, you know what? These are scary times. These are uncertainty. And when we're uncertain, we get anxious. When we get anxious, our whole bodies can shut down. And we want to make sure your heart rate is getting under 90 and, that kind of thing. So there's a lot that we can do. And the fact that we're all going to these efforts to reach out to one another and to help our patients is what's really critical. And I'd like to leave people with a really great reference. So the author is Deb Dana. She's a therapist that really has worked very closely with Dr. Porges, and she has a book called The Polyvagal Theory in Therapy, and it's called Engaging the Rhythm of Regulation. And it's an extraordinarily helpful book that people can get from Amazon or wherever they, get their books. And it does a nice layman's explanation of polyvagal and then gives lots and lots of different types of personal interventions that people can do to help themselves. So I would really encourage that book, or you can see both she and Deb Dana and Dr. Porges on YouTube, and you can hear him explaining his theory, and you can watch some interventions. So there's we're so lucky that we have electronics, and instead of looking at them as a burden, we can learn from this experience, but we can use it to help our patients.
Dr. Moller, it's been a true pleasure having you on the Psychcast. Hopefully we can have you back. I think that there's going to be a lot of heavy lifting to do, and we'd love to have you back on the Psychcast to talk about pretty much whatever topic that you want, but certainly we'd love to hear more about therapy, polyvagal theory, but also in regards to we never had a chance to really get into interdisciplinary care, things of that nature. So I'm really looking forward to having you back on the Psychcast sooner rather than later. So thank you so very much.
Thank you. It's been a pleasure.
And that concludes the conversation portion of our show. Don't forget to check out the show notes wherever notes are found in your app. We'll be right back with Precious Relationships and Dr. RK. Welcome back to the Psychcast by MD Edge. I am Nick Andrews. It's time now to welcome Dr. Renee Kohanski.
Thank you, Nick, for the introduction. We are physicians. We practice the art of medicine that is a combination of science, experience, intuition, and compassion. Lately, many people and organizations have been stepping between the doctor-patient relationship and misunderstanding this powerful relationship, particularly misunderstanding all the considerations we use when making a decision about when to use a treatment or not. We have governors prohibiting physicians from writing prescriptions under the threat of board sanction, and pharmacies refusing to fill prescriptions. I understand these are extraordinary times, and as in forensic psychiatry, one must balance the rights of the individual versus the rights of society. That balance is a very serious matter and is done with the utmost of consideration, utilizing the 14th Amendment of due process. But these are profound changes in the doctor-patient relationship being done right now. If we now forfeit this relationship because of these extraordinary times, we must be ever vigilant to go back and revisit these changes and establish parameters for the future. There is also tremendous misunderstanding about the role of the FDA and using a medication for its FDA-approved purpose. We in psychiatry live in off-label land. We and most physicians have long worked with understanding mechanisms of actions, presumed mechanisms of actions, or clinical observations because of dire needs of our patients. We utilize the precious concept of informed consent, of which I've spoken in other programs, to help patients make decisions about what is right for them. If there is an off-label treatment modality, alternative medicine, anything that could be of benefit to my patient, I want to know about it, and I don't mind being informed by any source. Ketamine was brought to my attention by one of my patients back in 2009. Another patient asked me about high-dose methylfolate as an economic substitute for a compound their insurance was not covering. They'd heard about methylfolate from a popular non-physician television host, hardly the most reliable of sources. We have a sacred, time-honored relationship with our patients. We have an obligation to provide them with the best available information we have. There is always a risk-benefit analysis to all decisions. That's why the concept of informed consent is so crucial and maybe even worth a review program here on PsyCast. We must remain ever vigilant to the creep into our doctor-patient relationship before it's irreparably damaged. I'd like to think that hasn't yet occurred. I'm Dr. Renee Kohanski for the MD Edge PsyCast.
And that's a wrap on episode 112 of the PsyCast. Let's get to this week's credits. The PsyCast is produced and hosted by the editor-in-chief of MD-Edge Psychiatry, Dr. Lorenzo Norris. Our guest this episode was Dr. Mary Moller. The Dr. RK segment is written, recorded, and produced by Dr. Renee Kohanski. The show notes are authored by Dr. Jacqueline Posada. The show is produced by MD-Edge editors Gina Henderson and Jeff Bauer. All MD-Edge podcasts are produced by the editor-in-chief of MD-Edge and Medscape, Dr. Ivan Oransky, as well as MD-Edge executive editors Mary Ellen Schneider and Kathy Skarback, along with multimedia editor Terry Rudd. PsyCast social media is produced by Kyla Clark. I am your audio editor, audio engineer, and the voice of MD-Edge podcasts, Nick Andrews. You've been listening to the PsyCast.